MRI safety is at the forefront of our profession. It starts with protecting Zone 4 and is why the ACR recommends using a caution barrier at the Zone 4 entrance. But what good is another sign in a room full of signs? Well, Aegis has created the perfect solution with TechGate Auto. TechGate Auto allows more focus on the patient and less worries about someone entering the room without being cleared. If you're serious about MRI safety, use the link in the description below to find out more.
Zone 3 Podcast. I am Robert.
Yes, and I am Reggie.
And today we are joined by Craig and Christina. Thanks for joining us. You're coming from San Francisco, UCSF, I believe, right?
Yes.
And we're here to discuss just hybrid environments with MRI. Mm-hmm. And that's kind of your area of expertise. I know you guys just recently kind of implemented a new area in your facility, right? Mm-hmm. Just maybe talk about a little about yourself, where you're from, your new sheepdog.
Yeah. Awesome.
Yeah. Well, I'm originally from Pittsburgh, Pennsylvania, and I've been out west for almost 20 years now.
Nice.
I've been at UCSF Medical Center for close to 18 years now, and about 16 years of that is in leadership. So I oversee a very large MRI department. We're looking at 3 hospitals with 7 outpatient centers and growing.
Wow.
And I've been in the field of radiology for a little over 20 years.
Yeah.
And then Christina, you are from?
I'm from California and pretty much spent my whole life in California. Spent a brief stint in my childhood in the South in Tennessee.
Oh, nice.
And returned back to the Bay Area. I started off in imaging in X-ray, went to X-ray school right after high school. That's when you could do that.
Yeah.
And they were desperately needing X-ray techs. And I've been in imaging ever since, and just went into MRSIM at UCSF and started off that safety program there. It was new. They brought in a new Siemens Vita, and then went to work in this role as a MRSO.
Nice.
Yeah, very cool. So is it Northern California?
Mm-hmm.
Always, right?
Always. San Jose.
'Cause there's like a rivalry, isn't there? Seems silly, I know. But.
I don't know.
And so what's your current role then?
So currently I'm the MR safety officer for all of the UCSF sites.
All 29?
Yeah, well, no,
Just
not
about,
really.
huh?
Well,
Okay.
yeah, I guess, including research.
Wow.
So
What
I
a
just
challenge.
need to spend more time with research.
Right.
And you'll see that's part of our talk is like having that governance over safety, regardless of where
Yes.
the MRI scanner sits. So.
Mhm.
Well, obviously,
Yeah.
right, because it's the same physics involved. So it doesn't matter whether it be in the ER, in the OR, maybe in a PET situation. But yeah, you're right. And so all those things considered, like what all environments are you mostly involved in?
Yeah, what is a hybrid environment, I guess?
So it is a atypical environment or a complex environment where you've put an MRI system in place. So it's usually outside of the normal diagnostic imaging department.
Oh, nice.
Mm-hmm.
And my only personal experience is we actually have an OR MR environment. And actually, Reggie works in it. Katie works in it. I do not. They won't let me. I don't know why.
He's too safe.
But there's other environments as well. I know there's ERs, like I mentioned before. There's PET and research as well.
Yep.
And so you're working with a lot of people who are outside of the whole world of MRI, and they're not as knowledgeable when it comes to MRI safety. So I imagine there's challenges with that, right? Learning curves and whatnot. What would you say is the biggest challenges with new staff in hybrid environments?
I think the biggest challenge just in general in a hybrid environment is that 90 to 95% of the people you work with are non-imaging personnel, and most of them haven't had any MRI safety training in their normal clinical training.
Right.
And so it's a re-education process on a daily basis.
And then do you have like an education, like training,
regimen or like a person?
like every 6 months, or maybe like they're supposed to be certified by going through a safety course or safety,
Because one
like
of
I
those
know
things that's
training of some
constantly-
sort.
It's just constantly evolving, right? like what the regulations are kind of going and just how
Mhm.
how we are like FMD wise, like the technology that's available to us to, you know, protect these environments. So
Right.
I guess how are you guys kind of keeping up with that?
Well, I would start by saying, you know, you need to have your everything in place at home, right? Like, so your MRI department within radiology should have all the top standards, you know, all the ACR recommendations, everything like that in place. But as you start to grow outside of radiology and put scanners in other areas, like you're mentioning, the OR, ER, you know, something like that, you have to be mindful that as you're mentioning, people coming in are, or as Christina's saying, like, you know, it's not their typical environment.
Yeah.
But the responsibility of the safety has to come from your MRI, you know, folks. So your MRSO, MRMD, MR leadership, everybody. So as you start to have these hybrid environments, you know, if you have a scanner in radiation oncology, it could be sort of operationally run by radiation oncology department,
Right.
but ultimately that safety has to be governed by, you know, the standards of your MR safety committee within the institution and whatnot. But when it comes to the training, because it's a unique environment, it's very important to hold sort of mock drills in a sense. And so if your standard in radiology is to, you know, never conduct a code or something like that in zone 4, right? We get the patient out, all that. That has to be the standard regardless of where the system sits. You know, in the emergency room, operating room, whatever. So I think holding those mock drills is very important to kind of continually educate a lot of the staff that are now involved in the process, where it's a very foreign environment to them. So, and maybe you can talk a little more about, you know.
Well, I was just going to add, you know, we have everyone who works with MRI has to take the level 1 safety training. And we have a learning module online at our medical center. And then if they're going to spend a lot of their time in MRI, then Craig actually designed and created a level 2 module.
Nice.
So that's a good, you know, the standard that we see, the 1 hour long, they have to pass and supply, you know, a copy of the certificate in order to even have, you know, badge access. So I'd say we start with education there. And then as far as the OR is concerned, I worked with the RN educators in the OR, and we created an RN MRI safety competency. And then we also created an OR competency for the technologist. So that's, you know, how we've been doing the safety in each hybrid environment. We'll probably have an ER competency and go from there, where we kind of partner with the other department.
And you mentioned a lot of people, that's not their wheelhouse, but they're in the environment a lot. Like my first thought is like making a nurse anesthetist doing a lot of anesthesias in the hybrid environment. And so through safety training, do you allow them access to these zone 3, zone 4s that otherwise wouldn't be, or they're still only...
I mean, I think ultimately it comes down to the facility, right? I think your MR safety committee needs to decide what's best. I mean, you figure you have small community hospitals all up to academic institutions, and it's not like the workflow isn't always going to be the same for to meet everyone's needs.
Right.
For us, we decided to control it as much as possible. So we really keep our level 2 access to primarily to people that spend 80% of their time in the MRI environment. So, you know, but with that, there's the annual training and screening that goes along with it. I mean, they go hand in hand.
Yeah.
So I think for us, like when Joint Commission comes through, you know, one of the things they always ask in MRI is, you know, like, well, how do you know if there's an ICU nurse or something visiting the department? How do you know, like, they're screened? Or if you screened them, how does your coworker know, you know, that they've sort of gone through the process and they're equipped and ready to be, you know, working in the environment for the next hour or something like that. And it was something we struggled with. And further that, you know, like screening forms have always been, you know, on paper. And we've had others, you know, external staff come down and then kind of not be comfortable with us taking their history on paper and then filing it away for our own records and stuff like that. So what we actually came up with, and it was, you know, it was a lot of work. It was very challenging, but we worked very closely with IT and occupational health to kind of get all of that electronically. So all employees are now screened annually through occupational health. So when they go in for their annual everything else that's required, flu shots, anything.
Right.
All that's on file through occupational health, and so is MRI screening. And then our staff are able to actually access that and then just see whether or not they're, cleared, not cleared to be in the environment. And then with that initial screening, they get a little bit of education for the environment, to be safe in the environment. But when they actually come down, because for someone it might be once a year, or for some people it may be every couple of days, whatever that they're visiting.
Right.
So we also include what we call just-in-time training as well. So when they do come in from zone 2, on, they get the just-in-time training as a reminder. And then they also have visual cues, and you can probably talk a little bit more to that, how we sort of tied, screening for everybody along with the training. So
Yes, we, as Craig was saying, we partnered with occupational health. So employees go online annually and they complete their MRI screening form. And then it's kept private. The occupational health keeps it on file there. And immediately when they're finished, they get a cleared or conditionally cleared result or not cleared. So if it's cleared or conditionally cleared, they can print that out, go to occupational health or any imaging supervisor, and they'll get a badge accessory that's color coded for the year, sort of like a flu sticker. And that way our level 2 personnel can see when that nurse shows up with the patient that they're compliant and they've been screened. If they're not cleared, the result goes not only to the employee, but it also goes to their manager, because obviously if they're not cleared, they're not going to get a badge accessory, and they need to hand off their patient care before they come down if it's like a bedside nurse in the ICU. So we let the manager know, not as a punitive measure, but so they're all on the same page. When they ask that they need coverage to come down to MR, it's easily given. And so once we do that, then they just update it every year. We have 3 attestations on the screening form. And the first one is that, if they have any implants from the time they first complete it, they should redo the screening. And that they will experience the just-in-time screening with the level 2 personnel when they arrive. That's their opportunity, or actually they're required to divulge their implant information, and that the MRI technologist will have the final decision as to whether that employee can enter with that implant. And then lastly, they acknowledge that when they come in, they're taking full responsibility of any accidental entrance of metal into zone 4, and that could cause serious injury to patients and staff. So we make it, very clear about taking that education and taking responsibility for it.
Nice.
So in an effort to avoid near misses, or do you guys have it with the patient or the outside staff, like they empty out all their pockets and put their stuff into a locker, maybe in a zone 2 or?
Yep. We have them come in to zone 2. We have temporary lockers, and everyone can take off their loose metal items. Of course, we have anesthesiologists and we have research, and everyone has a laptop and a cell phone. So if they need to bring those items into zone 3, because sometimes they do, just to access the programs that they need, we have a spot or a designated area, plastic bins, where they can store those items, and then they can walk over and get it and refer to it when needed. But we ask that they not sit, right close to the zone 4 door with it.
Nice. Well, I know, speaking of zone 2, right? Designing these environments can be kind of difficult, right? Depending on the situation. And I know you guys put a real great presentation together, just kind of talking about that a little bit as well. Did you want to discuss how, the importance of really breaking down the designs to be efficient in the hybrid environment?
Yeah, I'm going to let Craig actually start.
Yeah,
I think, just the years I've put in at UCSF Medical Center, we've gone through a lot of growth. So it's been interesting being involved, because I don't think everybody always has an opportunity to be involved in sort of building something from the ground up.
Right. It's pretty cool, right?
It is, absolutely. Yeah, it's a great experience. But I've been through a lot, so I've seen a lot of different. But I mean, one thing's for sure is you kind of come in to the table with, you meeting the architects and people that are involved in the project. And oftentimes, they have a lot of, they've sort of pulled together like something from like a prior project, or maybe what the hospital on the street did or something like that,
Right.
to sort of work off of. And it doesn't always necessarily, I think it meets most like recommended guidelines and stuff for like a layout. But it may not meet the needs operationally for like what your needs are going to be at your facility, or
Right.
the type of department you're putting the MRI scanner into. So, just because it worked for something down the street doesn't mean it's going to work for you. So I think it's important. And again, I keep going back to this, but having the right people involved in the process. Right. And I think it's something, you really need when these big projects kind of kick off. You really need buy-in from your senior leadership, executive level, whatnot, to make sure the right people are coming to the table. Sure. And again, that's bringing in your MRSE, like, someone with the physics background to work with the vendors and everything. Your MRSO to point out, where something might be, corners are cut too tight, and right. just, we need things to be adjusted and whatnot. But yeah, I don't know.
Yeah, so I know that came into play for the OR.
Oh, yeah.
So we have,
It's a big one, right?
right? So we have an OR intraoperative MR at one location, and the OR suite opens up directly into Zone 4, the magnet room.
Oh, right.
So it has those large kind of garage door sliding stainless steel doors.
Mm-hmm.
And so obviously that has a lot of inherent safety issues, because you want to make sure all of your equipment is pushed back, and
right.
your Zone 3 suddenly becomes a Zone 4 when you open up those doors. And so we are, Craig helped design a new OR, intraoperative OR at a different location.
Nice.
And we opted for a different design this time. So it will have the OR suite on one side, and then it opens up to a patient transfer room, and then you'll have the double doors into the Zone 4,
yeah.
right? So it does a lot of things. First of all, it makes the intraoperative doors kind of owned by the imaging department, because
sure.
that's been something that we've really had to address is, who maintenances that, who arranges that service contract, who's going to be scheduling that, offering supervision. I mean, it goes on and on. And so if you've got that whole MR suite to yourself, then that makes it easier to, handle that kind
Creates
of
kind of
work.
a buffer zone, right?
It's like a buffer zone, and it gives a nice spot to look at the patient bed and make sure there's no unsafe items,
Right.
and that you successfully transferred from the unsafe monitoring to the MR conditional monitoring. And there's a lot that goes into that.
Even to the pins that they use.
Exactly.
Right? Yeah.
Exactly. So right now in the OR suite, when we transfer, we have an MRI safety timeout. And so we do that in the OR suite.
Perfect.
Mm-hmm.
Nice.
With the RN circulating nurse and MR tech. We partner the two of them together.
Wow. Would you consider the OR the most difficult environment to kind of, the hybrid environment? Not
I'm going to say no. Craig may have an opinion on that, but I think every hybrid environment has its own caveats.
Yeah.
And
Right.
I mean, they're all
So-
challenging. So, but
they're all challenging,
unique,
just in a different way.
Right.
So like radiation oncology, there isn't any imaging personnel there. So the MRI tech becomes the person who's really instigating MR safety. But then there's the emergency room, and you can speak to how that design,
Right.
went.
Right. So we don't actually have that yet. It's something we're currently working on. But of course that, again, coming to the table with the architects and everything, like their first pass and like looking at the layout and the floor plans, everything. I mean, it was basically just another, like the CT scanner and MRI scanner were just another like room down the hallway in the emergency room.
Oh.
And, and immediately it's like,
Right.
no.
Right.
Like we really need like, like it needs to be like, if you're walking down that hall, you need to know that you're like entering into a brand new environment.
Right.
And this isn't just another
Its
room
own
off the
zone
emergency
two.
room. Yeah.
Right.
Yeah.
So, but then too, I mean, going back, like I kind of mentioned, like, building from the ground up. That's not always the case, right? Sometimes you're just stuck reconfiguring existing space and stuff like that. And, for us, like we added a PET MR unit in line with a few other MRI scanners at the site we put it in at. So all of our zones, everything was sort of already laid out and existing. But then like trying to like work that in was, you now need to include injection rooms and stuff like that. So we sort of had to reconfigure some zone 2 space and to make going into zone 3 work with these patients who now have sort of a different prep and workflow than just going in for an MR scan. So it all, really varies.
Do you find that just it helped to decrease the risk factor and also the susceptibility factor that maybe 1.5 should be the option chosen over a 3T? I know that in my experience, we have, like I said, a hybrid environment. It's in the OR. That's an actually 3T.
Right.
And I know it's a lot of times it's a radiologist preference, but from your perspective, being part of the design and seeing a lot of the outside stuff that comes with that, what's your thoughts?
I'm going to say they prefer the 3T because they need the image quality that they can get, the small structure resolution that they can get with a 3T. I know for MRI sim, you can't use any of the tips and tricks that an MRI tech would use in the imaging department because the software that they're contouring with needs true data. And so all of the things that I would normally like to use to, make an image great, but have it not take a lot of time, you're not allowed to use. So sequences on
even like
average,
deep resolve, even
anything that's going to take and manipulate the data, any kind of algorithm. So like average sequences are 10 minutes long and you struggle to keep them less than 15 minutes long.
Oh, for sure.
And so that's pretty important to just be aware of.
Right. And I bet communicating that to the patient is vital, right? As usual.
It is.
Right.
It is.
Right.
And it's interesting because in radiation treatment, you have to hold your breath for actually on average 30 seconds, which is unheard of, right? In diagnostic imaging, we're trying to do like the shortest breath hold possible.
Right.
But they're actually, the patients are trained using a visual graph to bring up their breath into a certain zone and then keep it for the 30 seconds while
in real time as they're being scanned. Ooh, I love that idea.
as radiation is being given to the tumor site. So
that makes the location more predictable too. I can imagine if they're kind of taking their breath at the same spot, because when you're trying to think about doing it, it's probably harder to keep taking the same amount of air in. So seeing a visual reference, I can imagine that being easier to take the same amount in. So that's pretty cool. I have not thought of that.
And also what I'm thinking about is when you consider MRI safety, we're talking about SAR as well. So if you're talking about 10, 15 minutes sequences, that's also a concern, right?
It is. And cancer patients have the highest percentage of implants. I think it's over 60%.
Wow.
So you have to take that into account. What implants do they have? Are they going to be able to do a longer sequence? And in some case, we wouldn't, and we would refer out and have it done in the imaging department on a 1.5 when necessary. And I think kind of the OR along the same question is the same way. We're doing primarily neuro studies. So they need the 3T for that, small detail, small structures.
So it sounds like you guys recognize zones in hybrid environments because you said you're always strive to be ACR compliant. I'm curious, have you ever thought about having like a dedicated level 2 train, like maybe it'd be a tech aide? We have one at our facility, Darcy. We've had another one before, David, and they're the ones that kind of are our buffer zone. So they're the ones that kind of we lean on to be our eyes and ears from entering zone 3 from zone 2. Do you guys have something similar to that?
Mm-hmm.
We do. Yeah, we work with the assistants that we consider level 2 personnel. We give them thorough training. They work only in our environment, so that's they live it, they know it well, and we rely on them a lot. But in additional assistants, we have radiology nursing that supports us. We have LVNs that pretty much in the inpatient setting, like man our zone 2 for when patients are rolling in. They're there to kind of greet and take care first point, but also that we consider them level 2 as well. So it's not just technology.
Have you guys implemented any kind of policies that help eliminate the potential for hazards? For example, I know our facility, I keep bringing it up, but that's my only experience, right? But when we introduced our first hybrid environment being, I guess PET MR was the first there before, but OR, they implemented a new policy where we weren't allowed to have scrubs with pockets. So now we're required to have pocketless scrubs.
Right.
Because with pockets comes things that are put in those pockets.
Yeah,
Right.
I like that idea.
Yeah.
Right.
I saw you perk up.
Well, that's a constant conversation.
Right.
And so I'm often reminding, everyone that we prefer non-metal items in zone 3.
Yeah.
And please, leave everything in zone 2. So it's just a conversation, right? Everyone
Right.
gets comfortable and relaxed. And sometimes as an MRI tech, you feel like this is my world. This is my environment. I'm okay with this little thing.
Right.
But I think what we all have to remember, and I've had this conversation quite a bit, is that we are the role model for the other departments that are coming to visit.
Oh, for sure.
And since we spend 80% of our time in the MRI environment, when you bring in that metal water bottle or, you have a non-MRI safe lanyard on,
Yeah.
just a lot of jewelry on, right?
Even one of those little big pins that have the springs in it. right?
Exactly.
Yeah.
When all of that is allowed, it's really hard to explain to the ICU nurse why she has to be so particular about what she can wear when she comes into zone 3, or why the patient needs to be completely undressed into hospital attire without any jewelry.
Right.
Which makes those annual safety trainings
exactly.
all that more important
Yeah,
and
exactly.
beneficial. Yeah.
So we have those conversations as well.
Yeah. And then it's going back to like what we were saying earlier, like, it's one thing to have it in radiology and these people visiting MRI, but when you're starting to put MRI in other departments
Yes.
where like all these other people sort of, for whatever one reason or another, need to be involved a little more.
Right.
It's very important to have that additional, maybe not just annually, but every 6 months or whatever, you find appropriate. Now you mentioned you guys have PET MR as well.
Yeah.
So is that in your MRI area or is that in your nuclear medicine area?
So it is, yes, in our nuclear med area. So it's in a completely different building. Well, not necessarily different building. We call it building 3. They're kind of connected, but it's like, I would say like 30-mile hallway to get
Seems
there.
that way.
Yeah, it's
Yeah.
kind of crazy. But it that environment is definitely a lot harder to manage, simply because it's so far away and it's a smaller space. And, we have a lot of staff down there that go through a different rotation, right? So keeping everyone trained up when there's like 100 people coming in and out is it's definitely difficult.
Right.
I think with our OR space is a little bit better because we're using the same neurosurgery staff, and same anesthesia people almost every time we're doing some of these cases, because it's really with the same doctors, right?
Okay.
Versus down with our PET, it can kind of vary a lot. So, and we do a lot of breast biopsy and stuff down in that area too. So we are like intermingling, and these people, I believe, are still level 2 trained. Do you know, Katie, if the zone they are level 2 trained still? So we haven't had any incidents, but it's still a challenge, right? And I think what has done well is that we try to create like an open door, right? Like if you have any questions about anything, like, please feel comfortable with just bringing that to us. Don't feel afraid that, you can't communicate. Because I feel like sometimes people are worried about communicating because they don't want to feel dumb or, they just assume. And we know what assuming does, right? So
I don't.
Well,
What is it? You're assuming I know.
Yeah.
No, but I mean, it's a good point, right? Because I already pointed out that like our
Right.
PET MR unit is in line with other MRI scanners, whereas yours is over nuclear medicine, probably in line with other PET scanners.
Right.
So it's very different, right? And that's the point I'm
Right.
trying to make is like, I think no matter, it's always like operationally, it's always like where you decide to put it and who's going to like operationally own it and stuff like that could vary, across
sure.
different institutions or whatever. But what's important is just to constantly, make sure that everybody understands is like that the governance over the safety always needs to come from that same starting point,
For sure.
which is, your MRI safety committee led by your MRMD, your MRSE, MRSO, and MR leadership.
It's a team effort for sure.
Yeah, and I was just gonna add on to that I think in the hybrid environment or complex environment, suddenly your MRI safety team looks a little bit different So you still have your MRMD and your MRSO, but suddenly now you need to add on a neurologist, or maybe you have an oncologist. So I know at our medical center, the oncologist that was leading or is leading the MRI sim program, she went ahead and got her MRMD. Though she doesn't have that imaging background, at least she had the safety part of it down. But they still, that whole group still umbrellas underneath the medical center's MRMD and the MR safety committee. And so we include them. And I think that's really important that you have the complex environments still kind of like umbrella up and you all align together in your safety policies.
For sure. I know a lot of places, kind of just speaking to the emergency department, MR, everyone wants to go door to MR when it comes to these stroke patients. And emergency cases truly give me anxiety when we're talking MRI, right?
Yeah.
So when you guys were thinking about design and just workflow implementation, because I know it's not completed yet, what kind of things are you taking into account to kind of, make the emergency thing happen?
Well, I mean, it's important for any of these hybrid environments. I think when you're coming back to the design and planning and everything, from the safety aspect, it's important, like what we keep emphasizing, that you have your core safety group that sort of has that governance, regardless of where the MRI scanner is situated.
Right.
But operationally and planning, it's very important that you include and work very closely with whoever it is, the emergency room attendings or the physicists in radiation oncology or whatever. But because you have to respect like their needs too, right? It can't just be like, well, because of MRI safety, like this is it and this is the only, so you have to kind of plan it respecting the other departments like needs. And then hopefully just like your final product is like, meets everyone's needs as well as respecting the overall MRI safety.
So it's like a huge Venn diagram, right? With everybody needs in it.
Well, it sounds like a lot of meetings on collaboration when it comes to that.
Yes,
Right.
I think that's super important. Super important. I know my partners in crime, so to speak, for the OR would be the RN educators. Like for radiation oncology, I'll sit in on their monthly meetings. But then we still have representation from them on our MR safety committee so that, you can speak to what you need or what you need support in, or, hey, do we have a policy for this? Or we're going to start this interventional procedure and I'm going to need some collaboration. And so they'll just reach out to Craig or myself or our MRMD director, right? And they'll say, we have this project. And then we usually end up tasking it and, looking at getting forward on that and having it completed.
Yeah. But I think one
in
important,
a safe way.
Yeah. One important thing to just put out there to the community or whatnot is, when you're looking at these procedures, right? The OR, for an example, usually everything's led by the direction of the neurosurgeon or whoever's, doing the procedure.
Right.
At induction time, it's the anesthesiologist sort of like calling the shots and stuff. But what's very important is that the MR techs are, sort of like know that they're empowered, that they're ultimately responsible to like, okay, yes, this neurosurgeon is sort of conducting and calling all the shots. But when it comes to safety, like it's on the MRI technologist to take that lead and make sure everybody around them is,
Yeah, well put. I've seen a lot of intimidation in those circumstances.
Yes.
For sure.
And justified too. I mean, you're in a room full of very, very smart people and you don't want to be the one that says, hey, you're doing something wrong.
Right. And actually that brings us up on a topic is we created an OR checklist.
Oh, nice.
And what it is basically is an MRI safety timeout. And so we ask the MRI tech that's working in the OR that day to go over and introduce themselves, find out who the circulating RN is going to be for the case, because the circulating RN, their job is to guarantee safe surgery. So it's a perfect pairing with the MRI tech. So we have the MRI tech check the door function in the morning before they start the case. They check the room because the equipment is set up the night before, and they add labels, MRI unsafe labels. We made the decision that everything in the OR is unsafe rather than have a mixture of labels between conditional and not. And so once they introduce themselves, they start the case, this checklist comes out, and we have all the roles stipulated. So the scrub nurse and the circulating RN, they do an instrument count, they do a sponge count, and then it spells out exactly like the RN's going to check the urinary catheter, right? Make sure there's no metal clamp on it. They then swap out the monitoring equipment. So they go through their steps. At the end, they actually look over to the MR tech and say, are we ready to proceed with an MRI timeout? Can we safely open up the doors? And then the MRI tech steps in, rechecks the patient monitoring. They do a second bed check. They survey the room, and if all the equipment's moved back, then they actually will ask who will proceed into zone 4 with the patient. They check that staff with a ferromagnetic detection wand. We make sure, the surgeons have emptied out any pockets or whatever they need to do. And then they give the okay to open up the doors and proceed.
Are you guys doing any procedures completely in zone 4? Or
I
is
would
it all
say
usually
they
OR
always
then zone 4?
induct in a separate area and then go into zone 4.
I see.
Is that for like the need of glytoscope or just because?
It's just because the anesthesia team likes their equipment, and they, I find, there's different needs for different groups. And so, one place I've worked, they had the anesthesia cart completely MR conditional, right? But at UCSF, they do like their equipment, and unfortunately, it's not MR safe. So we set it up in our, really it's zone 2 most of the time.
Nice.
But for the OR, it would be zone 3.
So all the more important to be running these mock drills, right? In the event we got to rush people out of there. And yeah, very cool. So we talked about personnel safety training, but we also now are kind of touching up on equipment. Now, what with with equipment also comes like maintenance to that. So I imagine PMs and whatnot, and so you have to have people there to make sure that that's done safely as well. Do you find that to be challenging?
Well, so Craig will probably laugh at this. It's been the intraoperative OR door has really been quite the hurdle, because you have 2 departments that partnered financially, and who took ownership of the door is a big question. And then what department is going to repair it or do the service maintenance? Is it going to be biomedical? Is it going to be clinical technologies? Can facilities do it? I can say that in our scenario, the door was not found to be a medical device, and so biomedical and clinical technologies could not take responsibility for the door. And then facilities felt it was too complicated, and so we had to go to an outside vendor, which is a whole nother, it's a whole nother thing. They have to go through a lot of screening procedures. And then do they have the right tools? Do they have titanium toolkit in order to do the repairs they need to do? I mean, it goes from there, right? Schedule, you got to block the OR schedule and block the MR schedule. And then who's going to provide level 2 supervision while they do the work that they need to do? So in our case, it's going to be me. I'm showing up at 5:30 or
so
6.
were those challenges kind of your motivation to create that buffer zone between the two, and so there wasn't direct access from OR to zone 4?
Yeah.
And so you can take ownership of the one door and they can take ownership of the other.
Mm-hmm.
Right.
And it's not to say for us, it's what worked best. I think through what we've learned over the years through different layouts and whatnot.
Yeah.
I think for us with the OR environment, we tend to try to avoid multiple doorways going into zone 4.
Yeah.
I think just having as minimal as possible is to be able to monitor and
for sure.
But it's not to say that the other way, doesn't work for another setup and operations. But for us, that's we try to keep those doors of zone 4 to a minimum, and it's nice to have that sort of stopping point right before you go in. And
so I know you guys have a few pictures of these sliding doors that we're kind of talking about.
Yes, so this is taken within our current OR at one of the campuses, and so the OR suite, this is from the OR suite perspective.
Okay.
So we put the danger floor mat down, as a way for the non-level 2 personnel to understand where to have equipment pushed back. Like it
Right.
can't be past that mat towards the door. And so they know to move all the way back. You can just kind of take a visual line across the whole floor
We got one
horizontally.
of those in here actually. So that actually we had one of those. It's a little bit different. Ours was
Mhm.
more of a rug, but it became a tripping hazard.
Really?
Yeah.
It
Oh.
would just kind of roll up, but it was
Oh.
because of the way the door would open.
Okay.
It would pull the rug
would
and
scrape.
Yeah.
Okay. So I've learned you have to place those far enough back from your threshold that the door doesn't scrape. It's kind of you just have to practice. Every door's special.
Right.
Yeah. Unfortunately, these doors slide open, they don't swing out.
Exactly.
Oh, nice.
Exactly. And so all of the repair work actually takes place. I don't know if you can see in the picture, but there at the very top of the door is a big metal box that runs the whole length of the door.
Yep.
Yeah.
So that's where the service and the repairs mostly take place. So super important that you block the OR schedule for this type of door to have the repairs done.
They probably need a ladder for that.
Can it be open from the other side?
So there's no way to really open. There's
can-
no buttons to open this from
this
this
room.
side.
This is an actual OR suite.
Exactly.
Oh,
This
nice.
is
So
the OR
the
suite.
only control is at the MRI tech station.
Yes.
Oh, perfect.
Yeah.
And that's
Nice.
even like locked.
Right.
It is.
There's a little lock box over it.
Mhm.
Master control, right?
Yeah.
So
So what happens is the tech actually stands on this side of the door with the circulating RN
Mm-hmm.
and the OR team. And when they're ready to open up the intraoperative door, they give the signal to their HA or the other MR tech that they're working with that day to press the button and open the door. So that's how we really control the movement of
but
it.
there's a whole timeout process before those can
Yes.
even be open. So
Yes.
Do you guys have
Mhm.
like a blueprint or like a picture of the other side or anything?
We do have a couple of design pictures with the two different OR suite styles.
Get
You
it,
know,
Katie.
one
Get
thing I
it.
wanted to ask you earlier, you mentioned that checklist. Is that
There
an
it
actual
goes.
physical piece of paper, an actual physical checklist that like goes in a medical record?
Yes. So we have the checklist that the RN and the MR tech sign at the end of the case. It gets
Mhm.
scanned into the patient's chart. But in addition to that, we have Epic. I know not all medical
Right.
centers have Epic, but if you have a hospital risk system, I'm sure the OR has their own preference cards.
Oh,
And
yeah.
so what we did, and this was in our partnership, is they created an MR timeout within the preference card. And so when we do that MR safety timeout, they actually notate who's present in the room on the team
Oh,
and that a full agreement was made before we proceeded into zone 4.
I like that.
So it's fantastic.
yeah. Oh, that's
Mhm.
nice.
hmm
Because I don't think we're doing anything like that. And I can
We
see
have the
power in
checklist,
that.
but not
Yeah.
that thorough.
Right.
And so this design is similar to the design that we currently have functioning. And you can see how the control room and the surgical theater both become zone 3.
Right.
And then obviously when you open up those doors, then the surgical theater becomes essentially a zone 4. So I think that's been the biggest learning curve with the OR staff is understanding how the zones are fairly dynamic as you work through the procedure. And this example has an outpatient setting to the far left.
Nice.
And so they're doing outpatients while the surgical case is happening because the neuro cases take, 12 to 18 hours
Yeah,
sometimes.
We do the same.
So it keeps the machine kind of doing those bread and butter cases.
for sure.
And we don't actually have an outpatient attached to ours, but they do come up from the main department, and that's how the techs continue to scan.
I see. And so the only access, because you can't get to the surgical theater from zone 3 or the control room, I should say, right? So you can only get there if you go out into zone 2 and then kind of get into there, which is, I think it's nice.
Exactly. And that's interesting because Craig can speak to this, but we started off with pediatrics
Nice.
using the OR.
Yeah.
And then the adult team wanted to mimic that workflow because they were taking their patient out into the hall and then entering MR through the hall.
Oh,
And so that was part of the workflow, was making the different teams comfortable with entering in this new workflow.
for sure.
Mm-hmm.
I like that. And you were speaking to how the door opens. So the door technically only opens if someone's in the control room, right? So they can only badge and open those sliding doors
Mhm.
from the control room, which I think is amazing.
Right, only the level 2 personnel can
Access.
go into the zone 3 and have access to the tech control room.
So, do you consider, I guess, that small space kind of close to that carpet area, like the virtual zone 3 almost, or is the whole surgical space kind
It's
of
the whole
zone 3?
surgical space.
Oh, okay.
So
Mhm.
this is not our floor plan, but it's very similar.
Oh, I
This is showing 2 doors into like the surgical space.
Mhm.
We only have a door that goes from
Ah.
zone 2 into that surgical space. So we
Mhm.
treat that door as if it's a zone 3 door.
I see.
Mhm.
Oh, nice.
And then I think there's another design next to that.
Oh, that's cool.
And so then this is the design that we felt would be an improvement, at least for us,
Right.
because it gave us a transitional space there in the middle to really take a look at the patient before they go into zone 4. And it helps like identify the staff, the OR staff that need to come into zone 4. And the rest of the staff and the OR equipment then stays obviously in the OR suite.
Oh, so the magnet doesn't move. That's right. It's just
It could. I mean, it's
Right.
one like design or layout that some manufacturers make it where the MR is on a track and comes into the
Right.
surgical space. We don't have that, and
Right.
we're currently planning for a new hospital, MR in the operating room, and we're looking at this design. So it's a fixed magnet,
right.
but then you can come at it from multiple angles, different procedure rooms. But there's one stopping point before you go into zone 4.
I like that.
Yeah.
And that just keeps things from having to be tethered, right? Like you can keep things out of your Gauss lines if they aren't, just like equipment, like anesthesia equipment and things like that might need to stay a certain amount of distance.
Mhm.
You can do that because it's a fixed machine versus if it was, one of the movement ones, you might have to kind of tether things because of how the magnet moves. So I actually like this design.
We're still tethering.
Still
Yeah.
tethering a little bit?
Yeah,
Oh,
we're
nice.
still tether,
Well,
yeah.
there's always benefits in tethering, right?
We just feel better.
Right. Right.
For good reason, though.
For
It just
sure.
it's just a nice reminder because we have again there's so many staff that are not MRI level 2 personnel, and it just reminds them, oh, this isn't supposed to go past
Right.
this line.
Right.
Yeah. So we just like that safety.
Right.
I'm a big advocate. That's my thing. I'm always saying to Craig, layers of safety,
right.
redundancy,
Can't
just
have
another
enough.
layer, tether, just another layer.
Right.
Do your techs, all of your techs go all different environments, or is like a select few of techs that do the OR, select few techs, and so on and so forth?
Mhm.
Yeah, I mean, we it's definitely specialized. So there's definitely competency to for someone to be able to go and work in that environment. We come from very large institutions, so I
Right.
think it's
Mhm.
better for us to have more people just for coverage and flexibility and
Yeah.
whatnot, and relief
Right.
in some sense. But yeah, I mean, you definitely want to keep it to like as a specialized,
yeah.
exactly, core
Mhm.
group.
Mhm.
But that being said, too, I mean, that's for us and our technologists. Now, I mean, you look at like someone like anesthesiologists or something. I mean, that's not always the case. I mean, for our pediatrics, we do keep it to a smaller core group of pediatric anesthesiologists. But on the adult side, they're a much larger section, and it's not always consistent. So,
Right.
And that's why I think it's important, no matter what, not just OR, but whatever the hybrid environment is, like whoever the other department that you're working with,
Yeah.
whether it's during planning or just during normal operations, whatnot, you always need a point person from each section, whether it's anesthesia, neurosurgery, nursing, OR
Right.
nursing, whatever.
Right.
Yeah.
One person that is involved in that planning, that
Mhm.
understands like the safety components and everything like that, but
Mhm.
also that you can go to because someone from their team may have been involved in a case that's not typically there, but at least you have that point who like that you can go to and say like, hey, we had this case, we need not that something went like seriously wrong, but
Mhm.
potentially could have been, and now we need everyone to like learn from that. So it's important again that you have
Mhm.
somebody from every section that is that point go to.
For sure.
Maybe it's that team safety officer or something like that. But
Right.
yeah.
Mm-hmm. Yeah.
Okay. Yeah, I think there's another blueprint there. Let's see. Now, when they say you help with the designs, did you kind of draw out on a napkin or a paper towel how you kind of imagine things originally?
Sometimes. I mean,
That's
honestly,
pretty
I think from my past experience, there's always been the first pass by the architects, and then
Right.
we've kind
Yep.
of taken shapes and actually like moved them
Right.
around on their plans.
Oh, that's pretty cool though.
Yeah, but sometimes I had to draw them out just to like show them like, hey, we're looking for something more like this.
Right.
And then I think just anytime you're planning architecture, like there's always many reiterations that you come back and.
Right.
But yeah, you got to find what works for you.
Right.
Again, respecting the other department's needs,
Right.
but also maintaining like our respective safety needs. So
Well,
What
I
about
think
the other
too, Craig, you were
Yours.
saying that it's important when you do the design that the company, the architect that you pick has created an MR environment before,
Right.
right? And then usually they bring a blueprint
Oh.
of a design they've done that was successful, and then
Sure.
you can come in then with your group and you can make it more individualized.
Right. Kind
Mhm.
of tailor it a little
Well,
bit.
because like you said, sometimes there's existing space and they might have a design that won't work with that, but it definitely helps, I would imagine, if you have somebody with that experience for sure.
Mm-hmm.
I think we already kind of covered that with the checklist.
Yeah.
Right.
Do you think there's anything that we kind of didn't touch on that's pretty important?
I just wanted to say that what works for our medical center isn't always going to be the right answer. Maybe for a different medical center, there's all
Right.
different sizes, number of people, and number of systems. So we just wanted to say that these are the answers that worked for us. And I think as long as you can start off with the right questions to ask, then the answer should always be focused on MR safety. You're probably in a good direction.
For sure.
But we didn't want to come across like,
this is
Our
the only way to do
answers.
something. Yeah.
Right.
No, I
Right.
think people understand. You got to tailor it to the space and the facility.
And all the teams involved, right?
Yeah, and I would just like add that I have friends in the community like all over the states, whatnot. I even talk to people in other countries, and I think one thing that's a struggle that's real is you don't always have buy-in from like executive leadership, because sometimes when you're talking safety and the needs and everything, obviously there's like a dollar sign always attached to that,
Yeah.
right?
Yeah.
And with budgets and whatnot, it can be very tough. So I think it's very important. We're very fortunate, I feel like, at our institution that like we really have the buy-in, and people respect the needs, and like we want to be as preventive as we can. So we're fortunate there. But if whatever it takes, I think, to meet with people and make sure they fully understand like why these needs are important, and then you have that support in a sense.
For sure.
Well, from a patient's perspective, it's nice to go to a facility that isn't cutting corners or worried about costs when it comes to the overall safety of the patient and
For
the staff
sure.
that are involved. So,
And they're doing cutting edge things like you guys are. So it's great. Do you guys have any positions open still?
We do have positions. Yeah. I mean, we're,
I definitely should put a link in the description then for sure. Right?
yeah, it would help. I mean,
Yeah.
the Bay Area is very large.
are you guys looking to get a 7T at all?
We actually have one.
Oh,
Yeah.
nice.
Yeah, we're looking at
Research.
upgrading that, but yeah, we have it for research already, and we're looking at upgrading it. So, and you did mention earlier about like 3T, especially in these hybrid environments and stuff like that. And I think historically, like there's always been this trend to move towards the higher field strengths, right? But I feel like we're reaching a point now as technology is advanced, gradient technology is much stronger and greater, software options, whatnot.
Right.
I think people are, looking at the flip side of, low
I
to
agree.
midfield strength again.
Yeah.
And
Right.
so it'll be interesting to see the direction things go. But I think, when you're talking about things like implants and stuff like that, I think it's going to make a difference. So, and I think we're sort of already starting to see that. So,
Reg, you've been on a 7T before. We were
I
at Cambridge.
did at Cambridge. Yeah. So, it was an interesting experience. If you want to know more about that, make sure you check the link in the description.
Yes, that's what I was hoping you'd do. Well, I don't know. Katie, can you think of anything? Because Katie, you definitely, this is sort of your wheelhouse as well. She's also our MRSO, and she's one of our hybrid techs. So,
No, I think this is great. I like learning the different ways that you can do everything because we do things slightly different even on some of the areas. So yeah, the
Yeah.
coverage is good.
Right.
Like you said, I think there's no wrong way of doing it as long as MRI safety is number one.
Right. Right.
So I like what you guys are doing. We always ask every guest towards the end. Are we at the end? I don't know.
Yeah.
So we'll start with the lady,
Mm-hmm.
Christina. What has been the most defining moment of your healthcare career?
I have two. Very early on in my career, I think my first position actually, I was in a trauma center, worst part of town, like high crime area where, people were rolled out of the car as it was still moving in front of the ER.
Oh, jeez.
And so I was placed on the trauma team and, wore a pager in those days. And that was so emotionally draining that was when I realized X-ray was great, but it just wasn't going to be what I could do long term.
Right.
Because I kind of felt like I came out of a war zone at the end of each shift. So that really propelled me into CAT scan, interventional special procedures, and then ultimately MRI. I would say the second defining moment was I'm actually a widow, and my husband passed away from lung cancer. His lung cancer was caused via biopsy by radiation changes during radiation treatment that he had received 30 years prior for Hodgkin's disease. So that is actually how I came to work at UCSF, is I wanted to join the radiation oncology department, make more precise radiation treatment planning so other families wouldn't experience what we did.
So it's close to your heart.
Yeah, close to my heart. So I still partner quite a bit with them.
Well, I'm sorry to hear that.
Yeah.
But that sounds like what a great direction for you.
Something
moving forward.
positive,
Yeah,
right?
absolutely.
Something positive.
For sure.
Mm-hmm.
All right, Craig, your turn.
Yeah. I mean, I love being in the field. I think as technology advances, so does everything we do, and that's really awesome. I think for me, I got into radiology at a very young age, and I did just general X-ray radiology. I did CT for a little bit. I think when I got the opportunity to cross train to MRI, it was
love at first sight.
Exactly. But I would say, like, because I got a young age, I think I reached a point where I thought I wanted to get out. So I was a traveling MRI technologist for
nice.
a short stint, but I mean, it was good. It gave me the opportunity to sort of see a lot, and I think now that I've gone down the leadership path, it was a great opportunity to like sort of build my resume the way I did by traveling, to pass through like all different size, community hospitals, academic institutions, everything in between, outpatient centers, whatnot, and learn a lot and see what works, what doesn't. And I think that really helped set me up for, being in a leadership role now. So
awesome.
Mm-hmm.
Well, we appreciate what you guys do. We appreciate your time. Thank you for
Sharing
coming.
the
Thank you.
knowledge,
All
your
the way from San Francisco
experiences.
on a great weekend. It's beautiful, like mid-70s.
Right.
Shopping time, right? No?
Or hiking time.
I think we're going to try hiking.
Oh,
Nice.
nice.
I would recommend don't doing Camelback on the north or the west side because that's kind of more treacherous, but
Okay.
that's where people end up in the trauma.
No,
But Reggie,
I mean, thanks to all our subscribers and just everyone who continues to watch week after week. We appreciate the love, and please leave a comment if you guys have a hybrid environment or questions or just experiences. Feel free to share. We love hearing what you guys have to say. So, thank you guys.
yeah, we appreciate you. Zone 3 podcast.
We are out.